Hi everyone, welcome to the Hair Loss Show. I'm Dr. Knudsen.
I'm Dr. Vikram Jayaprakash. Good to see you, Russell.
Good to see you, Vikram. So today's topic I wanted to talk to you about is, and this primarily concerns our surgical patients, is how much hair is enough. And this is a conversation that I think is very important because the basis of what we do when we're doing hair transplant surgery, hair grafting surgery, is we are trying to rob Peter to pay Paul, and this is a mistake that patients, often misunderstanding that they make, thinking that this hair would regrow, and therefore they've got unlimited amounts of hair to play with. But nothing could be further from the truth.
Correct.
And the catch-22 here is the balder you are, the less donor you have to play with, and then becomes a bigger problem to try and work out how to deal with it. So one of the things historically, because I've been in the field for so long, that was very important to me was understanding when, believe it or not, when synthetic hairs came into the marketplace in the 1980s, it was surprising because they were single hairs rather than the plugs that looked a bit, unusual. But it was surprising to me how happy the patients were with a relatively few number of these fibers in their head. And that's when the light bulb went on to me, thinking it's about the evenness of the distribution that gets people to a happy place. And the happy place they have is when they're going to see it and know it. But what we have, and a trend in the field at the moment, and this comes back to a lot of the lectures we've been listening to and the articles we've been reading recently, with the use of FUE surgery, expanding the donor areas past the scalp, for example, into beard hairs and body hairs, is this idea that you can make everybody look like Elvis by giving them massive amounts of hair and in a very short period of time in a young patient. And the problem with this remains that once you've taken 80% or 90% or 95% of the available donor hair and even harvested beard or body hair in this young person, the expectation is they're going to lose more hair. Then what?
Yeah, I think
we've got nothing to do, nothing to treat it with.
I think I'm really glad we're talking about this conversation because I think this is a topic that needs to be explored. I know there'll be a lot of people that will, have a series of negative comments on it because I understand the emotional impact that hair loss has. But understand it's a function of moving goalposts, right? Hair loss is, for a lot of people, the hair loss is starting at the front and the hairline is moving further back. But the same is true at the back. If you've got it balding at the back, the hair loss is moving from the back further down, which is reducing the surface area of your donor, your donor area, and essentially reducing the amount of hair that you're essentially able to use.
So the donor bank is shrinking
as
our patients get older, and this is part of the aging as well, because even the donor area, over time, the hairs in the lower part of the scalp, there's a subtle deterioration in the numbers and a subtle deterioration in the quality of those hairs as we age. Yeah. Right? So it's not like it's this stable thing that we're dealing with. The baldness, a stability, that are two words that really should be used together.
Absolutely. So if we look at the back of the head, we can say, right, well, this is for a lot of people the back of the head, and there's the ears there, and then we view in a large part our donor area that way. But for some people, over time, this balding area marches upward
from the neck.
This balding area marches downwards like so, and therefore what you've done is you're left with a donor area that is significantly smaller in surface area. How do you use that to create the Elvis look?
If we take more than 50% of the hairs out of that area, we're just transferring the baldness from the upper scalp into the lower scalp.
Yes.
That becomes see-through area, and that's a poor outcome. So I think the thing that I then understood when we went to follicular unit grafting, because we moved, the synthetic hairs came in the 80s, follicular grafting was the 90s, is that it was again evident to myself and other people working at that time that as long as the hair was evenly distributed, we weren't putting as much hair in to our patients as we thought we had needed to when we were doing plug surgeries. And that was good because the benefit there is that we're saving donor for future needs because of the progression of hair loss. And so what I say to my patients is, I don't know exactly how much hair you're going to need to be happy when we're thickening an area or rebuilding the hairline. I don't know it, and you don't exactly know it, but you'll know it when you see it. And I've got to tell you that to this day, because neither you nor I believe in doing high density transplants, it is a pleasant surprise to us how almost all of our patients come back saying, yeah, I'm really happy with this. This is really good. And we didn't have to use an enormous number of grafts to get there.
Yeah.
Yet when we look at the online advertising from colleagues and websites for Instagrams and stuff, they've all got these massive heads of hair in the photography.
And they're
dense,
offering mega sessions and
that's right, so
sessions.
4,000 or 5,000 grafts, and then they say, oh yes, we've got beards, so we put another 3,000 beard grafts in as well.
Yeah.
And as I said, you basically, by going down that path, you're not leaving yourself an exit strategy if things start to go south. And the expectation is that I can't tell you how many different excuses I have from patients finding ways not to take their medication over time. Oh yeah, I ran out 6 months ago. I've been a bit too busy to see you. And I've been without my tablets and I'm lost more hair. So the expectation is that you're going to have a lifelong potential problem. And if you go down the surgical path, you have to think of it as a lifetime potential problem and think about it, how you're going to manage that. And that's both the patients being educated properly and understanding it so that they don't ask for too much too early, and also for the doctors to understand that this instant gratification that everybody expects, I just want to have, when patients say to me, I don't want to take meds for the rest of my life, I just want to have one operation and have it done, and then I don't have to think about it again for the rest of my life.
Never possible.
And that's magical thinking, right? And instant gratification. It doesn't work like that. We're fighting a lifelong genetic problem.
I think one of the other things that we are experiencing is that with the explosion in popularity of hair transplant procedures worldwide, it's now becoming more and more accessible to more and more people, which is great. I think that's fantastic. But the problem is that the younger population that are experiencing hair loss, this is fast becoming an option for them. Previously, it was like, okay, I need to be on medication for a period of time, try and stabilize this, and then look to having a procedure. Whereas now people are sort of veering towards this being as, stage
surgery
one.
first.
Yes, and then worry about medication.
And then, now I'm losing more hair, maybe I better think about medication.
Correct. And the issue with, and that's one problem, just as an issue. But the other issue, the other aspect of it is that when you've got someone who's young and experiencing hair loss, let's say you've got someone who's 20 years old and has thinning and his hairline is moving back. Well, he remembers not too long ago what his hairline was at the age of 15, which is super low and super flat, as opposed to someone in their 40s, right? That would be, it's a lot. The time frame is a lot different. Therefore, the aspiration for both of those individual groups are different. You find that as well?
All the time. And so basically, when I talk to my patients who are 50, I say, we're going to take you back to 40 or 35.
Yeah.
Right. I don't say to my 25-year-old, we're taking you back to 15.
Yeah.
All right. I think that the 25-year-old is always going to want a lower hairline than the 50-year-old.
And the problem is that this conversation makes you unpopular with that, because there will always be someone who will tell them what they want to hear.
But it also requires more grafts.
Yes.
For these patients, right? Because if they want that lower hairline, they're using a significant number of hair grafts to get that lower hairline that might have been of benefit to them later on when they lost more hair.
I heard a really good statement, which I think really holds true, which is that there's two options. I can give you a low hairline, all right, or high density.
Yeah.
You can't choose both.
That's right.
Right? Because a low hairline with high density, by definition, uses up a phenomenal number of grafts.
That's right. And then you've got nowhere to go later on.
Exactly. And the problem that, just so that we're clear and we highlight that, is that the worst case scenario, I mean, that sounds great. Okay, I can have a frontal hairline that looks great, that, looks like Elvis, is super dense. But follow that on. Where is the problem? What is the risk? The risk is that you lose more hair. You won't lose the hair at the front where you've transplanted. You'll lose the hair behind that. And the risk is that you're just left with this band of hair, the solitary band of hair at the front. And then what are you going to do?
Well, patients say, "Oh, I just shaved my head." I'm going,
Yes.
"You think that's going to work, but in fact, it's still not going to look good."
Yes.
And that's the problem. So I'm of the view, because I'm conservative by philosophy, as are you, that I would prefer all of my patients to be on at least 6, if not 12 months of therapy before I touch them. That doesn't always work, but I like to do that because I like them to think about it as a comprehensive plan. You know, that 98% of my surgical patients will use medication,
Yes.
but 2% won't. They'll just say, "No, I'd rather have another operation in a few years' time." Well, okay. I mean, but the point is they're educated to think that way before they make that decision, because operating first and then medicating later is not a sensible way to do it, in my opinion. And fear of side effects is reasonable. I think we should all think about this. We've got young, healthy patients, and they're worried about side effects because they hear about them on the internet. The side effects are fairly mild and pretty uncommon if the patients are being treated properly with reasonable dosings. And I think they need a lot of reassurance about that. Parents need reassuring when they've got the younger children coming in their teens, for example, and 20s. But I think the message still is that if you can, just work on the principle, my philosophy is I want to make the patient happy with the least number of grafts I can, rather than the most amount of grafts I can. And that's where, unfortunately, we've got a big swing towards that sort of impulse in a lot of the clinics these days.
And the other thing which we should at least touch on is this sort of move into we've got other, we can expand the donor area by using other parts of the body. We can use beard, chest, back, everything. That's not the panacea, because there's very different hair textures and hair types that exist on the arm, the body, the beard. It will not look natural. You can't put
beard at the hairline, for example. It just looks wrong. It looks like a toothbrush when it's there at the hairline. And so, I know it sounds attractive when you go to a clinic and they say, "Oh, we'll do 4,000 grafts for X dollars." And then, I'm constantly justifying myself when they come to me and I'm saying, "Well, no, you only need 1,500 to 2,000. I'm going, "Why?" So because that's what's going to make you happy. And I'm saving the other 2,000 for later on. You don't need 4,000 to be happy. You only need 2,000. So what we're just to put it in other words for our audience, we're looking for cosmetic density, which isn't the same thing as mathematical density, right? Cosmetic density means putting enough in there for you to be happy that it looks like you're not significantly thinning. But once you go past that cosmetic density, you're wasting, in a way, your hairs, because it's not really improving the vision very much, but it's taking away a lot of available donor.
And there's a whole further conversation about why some clinics do larger numbers, and I think that's sort of a conversation for later on. But I think it is a really important conversation to have, to try not get sucked into the concept of more is always better.
That's right.
Because it doesn't always
and particularly when you have patients that are showing that they're going to have a large area of balding eventually, because you see this early thinning, right? I really only want to make them happy with the area that's bothering them at the moment, to save the rest for future needs, rather than over-treat this area and under-treat this area later on, because I can't do anything else.
Yeah. Cool. Okay. Well, like I said, I think this is an important conversation to have, because a lot of people who are thinking about having hair transplants do get sort of quoted large numbers, but be wary of that, because it's not always, as good as it seems.
And if a clinic advertises unlimited, grafts, run.
Well, very good. Well, thank you very much for watching this episode. Hope you found that useful. Please remember to like and subscribe to the channel, and we'll see you again on the next episode.
Thanks, everyone.
See ya.